The human immune system operates as a rigid, spatially precise architectural network governed by very specific histological microenvironments. This image shows the foundational stromal support, a three-dimensional meshwork of type 3 collagen, or reticular fibers. Their varying density dictates cell mobility. In wider areas, cells transit easily, while tightly packed fibers in denser trabeculae restrict movement, anchoring cells in place. Several core cellular players are embedded in this tissue: T and B lymphocytes, natural killer cells, and various antigen-presenting cells, or APCs. This diagram shows how adaptive lymphocytes are defined by their surface receptors. On the left, T cells utilize T cell receptors, which require CD4 or CD8 co-receptors to function. On the right, B cells rely on membrane-bound immunoglobulins to bind antigens directly. These naive cells are initially non-functional and potentially dangerous. They require strict histological education to differentiate self from non-self, a journey that begins in the primary lymphoid organs. The thymus acts as the primary organ for T-cell central tolerance. Originating from the third pharyngeal pouch, it serves as the essential site for T lymphocyte differentiation. Looking at a cross-section of a thymic lobule, the architecture is divided into two distinct zones: a dense, dark outer cortex packed with developing T cells, and a lighter inner medulla. In the cortex, naive thymocytes are isolated from circulating blood antigens by a blood-thymus barrier. Formed by squamous thymic epithelial cells and pericytes, this barrier prevents premature, unregulated exposure to antigens during early development. Inside the cortical compartment, stellate thymic epithelial cells form a unique cytoreticulum joined by desmosomes. This living framework physically supports and cradles the developing thymocytes, acting as the primary testing ground for their receptors. This diagram illustrates positive selection. Epithelial cells present MHC molecules to verify functional receptor binding. 80% fail to bind and undergo apoptosis. Surviving cells advance to the medulla for negative selection, where survival depends on not recognizing self-antigens. To prevent autoimmunity, medullary epithelial cells express the AIR protein, which allows them to transcribe and present peripheral tissue-specific antigens. If a T cell strongly binds these self-peptides, it is eliminated before it can reach the general circulation. The thymic medulla is histologically distinguished by Hassall corpuscles, large aggregates of epithelial cells that secrete cytokines. These factors are critical for the development of regulatory T cells, which maintain peripheral tolerance throughout the body. A failure in this anatomical development, such as DeGeorge syndrome, results in thymic aprasia. Lacking the necessary epithelial architecture, the body cannot produce T cells, leading to absent cell-mediated immunity. Surviving naive lymphocytes exit the thymus and enter peripheral secondary lymphoid organs, where they provide ongoing surveillance. This journey typically begins in the lymph nodes. Lymph nodes are organized into three tripartite zones: the outer cortex, deep paracortex, and inner medulla. The outer cortex is the dedicated B cell zone, characterized by spherical lymphoid follicles containing resting B cells and secondary nodules active in an immune response. Inside a germinal center, B cells undergo rapid DNA hypermutation to refine their antigen affinity. They are assisted by follicular dendritic cells, which hold antigen-antibody complexes. Situated directly beneath the B cell follicles is the deep paracortex, the designated zone for T lymphocytes. The paracortex contains high endothelial venules, critical portals allowing naive cells to leave the blood and enter the parenchyma. The innermost medulla contains medullary cords packed with plasma cells and medullary sinuses that filter lymph before it returns to the bloodstream. The lymph node acts as an anatomical funnel, structurally engineered to maximize the probability of a circulating antigen encountering its specific complementary lymphocyte. While lymph nodes filter interstitial fluid, the spleen provides systemic filtration for the entire blood supply. The spleen is divided into immune-rich white pulp and highly vascular red pulp. White pulp features periarteriolar lymphoid sheaths, cylinders of T cells surrounding a central arteriole to sample blood-borne antigens. Surrounding red pulp consists of splenic cords and vascular sinusoids lined by stave cells. Filtration occurs as red blood cells squeeze between stave cells. Macrophages in the splenic cords identify and phagocytose senescent cells that fail the transit. The loss of this histological interface, such as in a post-splenectomy patient, creates a severe, life-threatening susceptibility to encapsulated bacteria like Streptococcus pneumoniae. Guarding mucosal borders is mucosa-associated lymphoid tissue, or MALT. Although lacking a connective tissue capsule, it contains 70% of the body's immune cells. In the ileum, MALT forms massive clusters of lymphoid nodules called Peyer's patches, which monitor the gut flora from their position in the submucosa. This diagram illustrates the unique epithelium covering these patches. Interspersed among the enterocytes are M, or microfold cells. M cells lack a brush border. Instead, their basolateral membranes are deeply invaginated to form a large pocket housing a transient population of lymphocytes and dendritic cells. M cells perform transcytosis of luminal antigens, transferring them directly to the antigen-presenting cells waiting in the pockets. This activates a mucosal response, where B cells differentiate into plasma cells, secreting dimeric IgA back into the gut lumen to neutralize invaders before they can penetrate the mucosa. The palatine and pharyngeal tonsils utilize a similar strategy, but rely on deep epithelial invaginations, called crypts, to trap oral and nasal antigens. Chronic antigen trapping in these crypts can lead to pediatric adenoid hypertrophy, an expansion of tissue that physically obstructs the eustachian tubes. The adaptive immune system functions effectively because it is a spatially distinct, highly engineered pipeline rather than a random dispersion of cells. The primary organs, the bone marrow and thymus, serve as the engines of central tolerance and receptor generation. The secondary organs, such as the node paracortex and splenic pals, act as the arenas of peripheral surveillance and clonal expansion. Mastering the exact histological zoning of these organs provides the anatomical logic required to diagnose and treat profound immunodeficiencies in clinical practice.